All right, so just to reset, I'm Chet Donnelly. I'm a spine surgeon in the same city I was born and raised, and that's here in Dallas, Texas. I'm board certified. I do everything from the skull down to the pelvis. I like to start with kind of a little anatomy lesson. I like to kind of answer some questions. I can't give any advice. I don't want this to be a marketing thing. I usually jump on here for about maybe 10 to 30 minutes, just depends, honestly, on when my kiddo wakes up from a nap. And haven't done this in a couple weeks just because the weekends have been pretty busy, but let me kind of jump on here, answer some questions. I'll do some rapid fire questions. I'll talk about technology of 2025. I'll talk about non-operative care a little. Again, I'm a spine surgeon, so I kind of specialize in the surgical aspects of getting better. But you let me know what's best for y'all to talk about, and we'll get from there. So let me kind of just jump on, hit some of these questions. Again, appreciate the likes, appreciate the shares. That helps promote this to your peers that maybe you're going through the same thing. You can always subscribe, and it'll give you alerts. So with that, let me kind of jump some questions. So from Tinkerbell Fairy, it says, I have a chronic back pain. What must I do? Well, we got to figure out what's causing your chronic back pain. I know it sounds like a silly answer, but that's one of the things. Another thing is how many years of education? I don't know off the top of my head. So it'd be 4 years of college, which fine, everyone does. Not everyone. 4 years of college. Then after that, it's 4 years of medical school. Then after that, it's 5 years of orthopedic surgery residency. And then you have the choice, which almost everyone does, 90% do that, 1 year of a spine surgery subspecialization. There's about 8 or 9 subspecialty fields of orthopedics. You got sports, orthopedy, oncology, trauma, arthroplasty, upper extremity, hand. So there's a bunch. Spine, I jokingly say, is the best, and that's why I did spine. How can I get, a couple other questions coming in here. How can I get, I just missed that question. I apologize. From SCMV Ball, I have severe spinal stenosis at C5, C6, and left arm pain. Well, that kind of makes sense. Well, let me tell you why it makes sense. Look, you have different bones in the neck, just like this. It starts at C2, goes all the way down to C7. In general, different nerves go to different areas of the shoulders and the arms. If you have a MRI that shows you have an issue at C5, C6, that hits the C6 nerve. That's not an obvious statement. That's, once you know anatomy, that makes sense. But at 5-6 is the C6 nerve. The C6 nerve classically comes down the arm, kind of on the side part of the arm, goes to this, sort of the radial part, or the inside part for those non-medical people of the forearm. Kind of goes to these fingers here. This is C6. The middle finger, which I'm not going to just do, is C7. And the outside here is C8. Kind of all the fingers can be T1, but different parts of the spine and the cervical spine go to different fingers. Now, there's a ton of overlap. C6 and C7. There's a great study by, I think his name is Rainville, maybe in clinical spine surgery, that talks about the huge overlaps of C6, C7. So I sometimes jokingly say that not all patients read the textbooks of how their spine is supposed to present. But if you have pain shooting down, you have stenosis at 5-6, makes sense. A couple of different social media platforms going on right now as we speak. So if you see me looking from one to another, answering different questions, we have about 1,500 people on all these different platforms combined. So it's a lot of people from all over the world, and it's great. So let me get to Pilly. Pilly, I think I've talked to you a lot before. We're going to talk to you again. It says, hi, doctor. With the spondylolisthesis operation, are there any advantages of going from the side rather than your back? God, so much to break down on that. Okay, the simplest way I can make this, where if you need a spine surgery, not all of those need to be a fusion. Most of them don't need to be a fusion, and those that are a fusion, you got to get you don't have to, most do these days, and should, get a cage in there, a cage that goes in between the disc spaces, and that accomplishes many goals. That's a whole different conversation. But there's 3 ways, kind of 4, but 3 ways to get in a cage. You can go through the belly, which is a fantastic way. And this is for the lumbar spine. You can go through the side under the ribs, fantastic way, or you can do it all from the back. That's the traditional all good way. The disadvantage of going through the back is you have to usually open up more muscle, more tissue to get there, and that hurts, and there's stuff associated with that. Going from the side is a great way. You can get one of these big lateral cages, and that's great. But you can only do that at L1, 2, 2, 3, 3, 4, sometimes 4, 5. Can't do it at 5-1 because of the crest. And then going through the belly is a fantastic way to put in one of these big cages, restore lordosis. Some would say that's the gold standard for L5, S1. but it's all based on your vascular surgeon. You need an approach surgeon. There's some regions of the country, many where they don't have a vascular surgeon that would even do that at 4 or 5, which blows my mind, and they won't even do it above. I live in a community where I have like the best vascular surgeon in the nation, and no level scares them because they're just so experienced. So the long answer, short, Pilly, it kind of depends on what level your issue's at. It depends on the tools your doctors have. There's many studies that show that all the ways are great, and it just gets to be a little bit of a debate. Everyone thinks their way's the best, but usually for 4-5 and 5-1, if you have spondy, I think going through the belly is gold standard. It's a great way to do it. Some people don't want to go through the belly, but I usually can tell them why I know that's the best way to do it. So, cage destroyed my mom's health. Well, I'd love to know why you think that. It's not like I don't think a cage itself could do that, but I don't know the whole situation. Sometimes patients come in with a burnt car that's rolled over and totally totaled, and they demand a spine surgery to fix it, and you do a spine surgery. You can't fix a totaled car sometimes, but you can try. A couple other questions. My spine surgery only worked for 10 years. I needed another. Well, that's, when you say only worked, my goodness, it's like if you have to bring your car to the shop every 10 years and you're not getting mad at them that 10 years later you need to go to the car shop again. So there's a lot of joints in the spine. There's a lot of different parts of the spine. It's like if you got a knee replacement on one side, you're not going to get mad at that doctor if in 10 years from now you need another knee replacement on the other side. It's just a whole other joint. So just kind of conceptually, people sometimes are fearful of spine surgery, but they just need to kind of understand it's multiple levels in the spine. They're somewhat connected, somewhat unconnected. It just depends on how it goes. Question from Johnny K. I have retro on L3. Is there a non-surgical solution? You might not even need surgery for retrolisthesis. Just depends on the symptoms. Usually that means your body's compensating, trying to put itself into a better position due to the areas below having issues. Secret iliac fusion, thoughts from Hawkfan. Hawkfan, my thoughts are if you're going to have an SI joint fusion, you should have a spine surgeon do that. It's a spine surgery. Have a spine surgeon do that surgery, not someone that's not a spine surgeon. Again, appreciate the likes, appreciate the shares. Just as a reminder for, I got about several hundred people, my friends, subscribers on here, prior patients on here. They can help validate me as a good person, nice person, and ethical, and I think very good a surgery person. But just reach out to the other patients I have, even in the chat room. You can see there's many, many people here. But as a recap, I'm a spine surgeon here in Dallas, Texas. I jump on here on the weekends for a couple 15 minutes at a time, 30 minutes at a time, just depends on what I got going on that weekend. A couple other questions from Noel. I have a 3-level thoracic laminectomy. Is that common? It's not common. It'd be, it's not common. It could be from a tumor or a trauma, but thoracic spine surgery is not that common. But it's, when it's needed, it's needed. Spine surgeon through the belly. Have you had many abdominal adhesions? Is that recommended? Spine surgery through the belly is definitely recommended if that's what they have. In terms of abdominal adhesions, I don't think I've had any, but it'd be just like, how did this present? Maybe that's something that presents like 5 or 10 years later. Is that really from that spine surgery? A little hard to say, but I don't know if I've never known of anyone having an abdominal adhesion or any abdominal complication as far as I know of. So not sure how to answer that. My husband needs an L5-S1 surgery. How successful is it? Just depends. Depends if they're going through the belly, going through the side. Depends if they're doing a fusion, non-fusion. That's just a loaded statement. Are they doing a laminectomy? Are they doing a microdiscectomy? So it's just hard to say how successful it is because there's just like 40 different things you can do at L5-S1. What's my background? I'm an orthopedic spine surgeon, board certified. Where did I do my training? University of Miami. I consider that one of the best orthopedic programs. Someone asked why earlier. It's like, well, look, New York City and Los Angeles is great, but if there's a million programs in your city, there's a million hospitals, all that experience is getting divided out, so you're not getting that high volume. Another thing about, I always say, New York City is you're not falling off of roofs in New York City and surviving. Those are skyscrapers. In Miami, you have 2-story houses, 3-story houses. You have buildings. You fall off that, break your leg. You fall off a highway on a moped, you break your bone. That's just a lot of orthopedic trauma that you get very experienced at. So not all programs are created equal, but I'm a big fan of University of Miami, but I'm obviously very biased. Do you know of a good military spine surgeon you would recommend? I do. He's actually extraordinarily good. His name is Karthik Shenoy. I was just trying to think of where he's located. He's located in Vegas. He's at, I forget the name of the base, but Karthik Shenoy, Shenoy, Karthik Shenoy. He's not just one of the best military spine surgeons. He's my best friend and extraordinarily good. Next thing, have you ever seen a syringomyelia? No, I don't see too many of those. Why would a surgeon remove a vertebrae? Could be cancer, could be trauma, could be severe arthritis. Is cervical pannus concerning? Not necessarily. Usually you have a cervical pannus that's in the top part of the spine. Usually you have an underlying diagnosis of rheumatoid arthritis. Karthik Shenoy, it's with a K, Karthik, Karthik, and then Shenoy, Shnoy. So hope he sees this video one day. He'll be very proud. Gabapentin for pain med, off-label. Why not a pain med? I don't prescribe gabapentin too much. It's more of a chronic pain medication. I defer that to my pain colleagues. A couple other questions. I'm a 7-year-old having fusion, ALIF 4551. Anything to worry about? Sure, Stephen, there's a whole lot of things to worry about. You know, it's a big surgery. I like ALIFs at 4551, but, you know, I wouldn't say there's nothing to worry about. I would say having a good bowel regimen beforehand, exercise, being as physically fit before surgery as you can be would be great. A carbohydrate loading the days before surgery is a really helpful thing. Is a really big deal. Post-op, definitely things to worry about. Non-union, infection, vessel injury. So there's a whole lot of things. I'm not trying to downplay it. I think the complication rates are extremely low when certain doctors do it compared to others. I think you'll do great. Dante, to answer your question, there's just so many things about that experimental stuff. First of all, it's cash payment. So one of the risks is you pay all this cash and it doesn't help. Two, it's that, golly, there's not a bailout. If that doesn't work or if that wears out later on in life, you are toast, my friend. But if you want to travel across the country and pay cash for an experimental surgery, I think everyone's just going to say go for it. From Florida, do you like the barricade? Okay, well, I hate being so negative here today. I feel like people keep asking about things I don't like. But also, to be fair, if you're on social media, you probably see a lot of these gimmicky things. And so maybe you're more experienced than others in terms of gimmicky spine products. I do think the barricade is in that category. I don't like the barricade device. Look, having a recurrent disc herniation, is it super uncommon? Does the barricade stop that? Maybe, but it also really damages your end plate. There's like legitimately very good studies that have shown that. And then say you need another spine surgery in the future, 10 years down the road, now you have this implant there. If you do an ALIF, are you pushing that out? It just doesn't seem like a good idea to me for something that's not an issue. I feel like Epic Systems are a bad organization. Is there an executive thought on to be thought of? I like Epic in terms of a platform. I've used others. MedTech's terrible. Epic's good. Patient Keeper I think is pretty good. I've used a bunch. I just sometimes can't. Cerner I think is fine. Might be one of the things you get what you pay for, but I'm not really on the executive side of what hospital system buys what service. So I don't have a good answer. Have you heard of the intercept procedure? I have. The intercept procedure is a good procedure. Essentially, that's when a pain doctor, sometimes spine surgeons do it. Pretty much they put a needle into the bone in the lumbar spine and they burn the sensory nerves in that bone. It's an okay option. I don't dislike it at all. I think there's a narrow window where it helps patients, but there's pretty little downside, so I support it in general. From Terry Tanner, I have a 7mm bulging disc. Do I need surgery? Are there other options? No clue if you need surgery or not. Surgery is all based on the symptoms. Do you have spinal cord compression? Do you have weakness in the arm? Hard to say without knowing the whole story. From Mitch, what's my thoughts on chiropractic care? I just support chiropractic care in general. Specifically, there's actually this group in DFW. I have no financial ties with them called Erosti. The reason I kind of like this Erosti group is they don't pop your back or try to pull you apart. It's got physical therapy plus chiropractic therapy. So if you're in the DFW area, tell them I sent you. Again, I have no ties from them. I don't know if I've ever even received one patient from them as a referral source, but the more I've gotten to know them, some of their leadership, I think it's a pretty good source. If you're not in the DFW area, look, I support chiropractic doctors. Whatever we can do to avoid surgery is great, right? I do support that. But I don't support like crazy popping, twisting, things like that with the spine. It's just there's no need for it. Which branch of the military is your friend in? Ooh, I'm so embarrassed. Do I not know this? Uh, Army or Air Force. You know, he pretty much joined the military when he joined medical school, and like they paid for his med school, and he's doing a service now. I think it's Air Force. The more I think about it, he'd probably murder me for not knowing, but he's already done his deployment. I think he's Air Force. Sorry for not knowing. Worst after an RFA, why? I don't know. Probably Air Force is what Cuba's saying. Yeah, probably Air Force. I kind of think it's Air Force. I'm not sure. What should the thecal sac be cervical? There's different lengths for different people. You would need it to be more than 14 millimeters, or else it could be compression. Some people have something called congenital stenosis, where you're just as smaller at baseline. Okay, let me take a little break from everything. Getting and answer a couple other things. So I get asked a lot about disc replacements. Here's an example of a 2-level lumbar disc replacement. They're a good option for very, very narrow indications. The reason that I like disc replacements, but also hate disc replacements, is I see way too many people that like are in so much chronic pain, so much acute pain. They have weakness, and they legitimately are going to have 20 different orthopedic spine surgery appointments with maybe 5 different people trying to find a disc replacement when it's just not indicated. So like, I like disc replacements, don't get me wrong, but if you see 1 or 2 doctors and you have other friends and family who've seen them, so like, I guess you validated them somehow, right? And they say don't do a disc replacement, don't go travel across the country or pay cash to get a third opinion and finally pay for the answer you want. So that's my only kind of beef sometimes on disc replacements, is that disc replacements are great in the narrow window they're indicated. If you got the cash, you'll find someone to do the surgery that you want. That being said, fusions do great. Fusions have a great track record for certain pathologies. And that's just my only thing I can tell you about that. From AirV77, endoscopic surgery. Endoscopic surgery is interesting. That's something they've been doing in, interestingly, Korea, South Korea forever. Pretty much, it's instead of like when I do a microdiscectomy, I use a tube that's 18 millimeters. So I don't know how big my finger is. Maybe if you're looking at my finger, maybe that's 18 millimeters. I'm trying to think. Your index fingers, probably the circumference is 18 millimeters. The endoscopic is 8, so it's a difference of 10 millimeters. I know all of us are American, not all of us, but most of us, we don't use metrics. But you're talking about the difference of this versus this. I have a big finger, so not totally different. But and then you're looking through on a TV screen, you're using water versus the other thing, like your actual hands are on it. So and I'm not ripping endoscopic spine surgery, don't get me wrong, but a lot of the studies have shown equivalent outcomes, which is great news to hear. Longer surgeries, more anesthesia, higher healthcare cost. To be half fair, if you're the patient, you don't care about healthcare cost. You know, it's the insurance companies have to pay for it for the most part, or the hospitals that lose money on it. But from a global, realistic standpoint, you know, if it's more expensive to do something for a 10 millimeter difference, that's something to think about. There's also a learning curve for the surgeon. So as a surgeon just doing it from a marketing standpoint, how many cases do they have to do to get confident in it when everyone's already been doing it through an 18 millimeter incision? So I think endoscopic spine surgery's got a great role. I don't have bad things to say about it. I can just see why some people don't like it for sure. From Crystal, I was just denied surgery for a grade 4 spondylolisthesis. Goodness gracious. I'm so sorry to hear that. Let me see what this says here. Because I'm naturally fused. What can I do? I don't know. I got a lot of thoughts on that. I haven't seen too many. I mean, grade 4, pretty surprising. And then if you are fused, then you don't need surgery, I guess, because you shouldn't be having the pain. So I'm just a little. There's a lot going on in that statement. So I don't have a great answer for you. Does my practice accept VA patients? I accept one of the TRICARES. There's 3. I'm not sure which one. Do you know if hemangioma is a problem? The majority of hemangiomas are no problem at all, no issue at all. Sorry, I just heard a noise. Let me just see if it's my little kiddo. Can't tell, it's so dark on this thing. Nope, all good. Just to reset, I'm a spine surgeon here in Dallas. What I'm checking, I have a 3-year-old cute little man who is taking his nap. Sometimes when he naps, I jump on here. So when I abruptly have to go, it's because he's waking up and I like to go wake him up. From Noel, does hypersensitive nerve pain go away after a few days or weeks after a spine surgery? Usually after a few weeks, it does go away. It's not uncommon to have worsening nerve pain after a spine surgery. That happens sometimes just from pushing the nerve to the side, pulling the nerve to the side. not totally unheard of. It stinks. We don't like it, but that happens. Someone said Shinoi's Air Force. Good. You looked him up. Well, tell him I said hello. He's one of my good friends. He'll enjoy knowing his ears were burning today, hopefully. How long does it take to heal from a microdiscectomy? Maybe 6 weeks, if that. Just kind of varies from different things. Appreciate the likes, shares, and subscriptions. If you guys can keep hammering that, maybe we can get to 5,000 likes. That'd be wonderful. The only reason I care, that kind of helps push this to other things. What about the titanium-linked Alzheimer's from a disc replacement? I've never heard that. I didn't know titanium leaches out and you call it Alzheimer's. I don't know if there's any study that's ever shown that. I would also just very arrogantly say, goodness gracious, of all the things and the toxins and exposures we put our life through, you think it's a disc replacement that's causing Alzheimer's? I don't know about that. Additionally, disc replacements are, in a way, only for the young, only for the 20-year-olds, 30-year-olds, maybe 40-year-olds, because after that, you have too much advanced stuff. If you get Alzheimer's, you're usually in your 60s, 70s, 80s. So I'm a little surprised that there'd be enough data on that many patients who got it in their 40s or 20s that now have Alzheimer's. So I'm not sure about anyone's ever said that before in the history of conversations, but maybe. Does the titanium leach? I don't believe that. No, the titanium does not leach. Never heard that in my life. Another question from Leanne. My dad is getting surgery on Tuesday. How common is it doing an ACDF, anterior and cervical surgery posterior? It's not that common, but it's not a bad thing. That just means they have a really big issue. Look, that's one of those surgeries. That's a lot of work for that spine surgeon. You know, they're not looking for a dog fight sometimes. So if someone needs a big surgery, someone needs it. Can people get Alzheimer's at 37? What are the signs? Not really sure. That's way outside of my scope. I'm not really sure. So I can kind of guess, but I'm not sure. Can you work at a job as a nurse after a fusion? For sure. Well, it'd also be, is that a neck fusion? Is that a spine fusion? Is that a 1 level? Is that a 20 level? So a lot of things to discuss with that. But yeah, you can go back to, professional sports after 1 level fusions, no problem. Next question, interestingly, is from does sitting, standing, or laying flat on an MRI make a difference? It does make a difference. The standard of care is laying down on an MRI. That's just how almost all of them are done. But there are probably some pathologies that are missed and that are shown better when you are standing. That said, sometimes the standing MRIs are lower quality. But there is definitely an argument to be said that if you could get a standing MRI, that'd be wonderful. That being said, you need to stay still that entire time. If you're having a lot of pain, that's hard. Sometimes the quality is different. But yeah, if you can do a standing MRI, that'd be great. But it's pretty rare, maybe once a year, that I ever order a standing MRI, and that's after we didn't see anything on the laying down MRI. So. Interesting question. I don't think about that too much, but that's something. But I wouldn't go out of your way to find a standing one. Hi there, help. I was hit in a hit and run. Oh, I'm so sorry to hear that. Would love to know what happened. So much I can do. Okay, so from Racky36, severe sciatic nerve pain, physiotherapy, no help. What else can I do? Well, I've got a spine surgeon kind of run the course with that. There could be certain things that a spine surgeon could guide you on, such as injections, medications. A little hard to say. There's also surgical options if they can prove what's causing it. Going to do a little pause and just go over a couple things just in terms of spine anatomy and reset. Again, I'm a spine surgeon here in Dallas, Texas. It goes bone, disc, all the way down. These are the nerves that come out. This is the lumbar spine. Similarly, we have this is not actually a cervical spine model, but this would be the cervical spine. So kind of like this and this. The reason people have issues with their spine is usually one of 3 things. It's usually 1, a disc herniation. So a disc comes out here and pushes on the nerve, causes numbness and tingling going down. Pretty darn painful. Number 2, you could have joint arthritis or joint disease that either creates thickened tissue, arthrosis, that pushes on the nerve. It could also cause my favorite thing to treat. So if you have this on your MRI and you're looking for a surgery, I'd love the opportunity to fix it, but it's something called spondylolisthesis. That's when one bone is slipping forward on the other. One bone is slipping forward on the other. that is an issue that can squeeze the nerves. And you can also lose all this disc height here. So if you have bone, disc, bone, bone, disc, bone, and you lose that disc height, a little hard to show in this model, but you can kind of imagine if I squeeze this down, you know, it's like those medieval guillotines where it comes down and it's just cutting this nerve off, squeezing this nerve. That hurts also. Different nerves go to different areas in the neck. This C5 is usually shoulders, bicep. C6 kind of comes all the way down. It could be shooting finger, C7 coming down, tricep also, C8 over here. And the lumbar spine is on the front of the thigh. That could be like an L2, L3. Side of the thigh is usually like an L4, can be L5. Side of the thigh down the back can be an L5 or S1. So there's just a lot of different nerves that can be causing different issues. Either way, you know, there's other reasons nerves can get pinched. That's usually the three most common. A disc herniation pushing back, spondylolisthesis, could be from a pars fracture, could be from joint or facet arthritis, squeezing of these nerves, moving the bones back and forth like this. Well, you'd see that both on your x-ray, but not a lot of people have x-ray reports because those are done in doctors' offices. So on your MRI report, if you have grade 1, 2, 3 spondylolisthesis, most of them are grade 1, that's an issue. And then loss of disc height, squeezing right now. So what would I do surgically? Well, first of all, I try to get better non-surgically. Okay, but you're reaching out to me because you want surgery, right? Like people that reach out to me that don't want surgery, it's fine, flattering, but again, I'm a spine surgeon. So if you're like reaching out from across the world for non-surgical options, I scratch my head sometimes, but I have many patients from Dubai and Kuwait all the time. And the surgery to fix that would be similar to this. Depends what the issue is, but like an L5S1, bone, disc, bone, the thing I like to do is place these spacers here, just like this. This is an A-lift spacer. This is a really high-tech one. This one's kind of on the market, kind of not on the market. You're like, what does that mean? Well, it's very high-tech. This is almost a prototype for it, so I can't share it completely. And that's the reason I have it. But you can imagine it'd be like this. If it went in there, I'm trying to make it so this holds up and shows on the screen. But you can imagine a spacer going in there. It opens the bone tunnel back up. It gives you the curvature back, and then it locks it into place. Again, this goes in all the way through there. So almost like going on top, you know, right through there. You can imagine it just like that. I can show you just like that. Is that photographing well? Not really. Either way, you get the idea. Goes in there, opens up the bone tunnels, curves the spine back in the right position, and you lock it in the back. Sometimes with pedicle screws, it just depends on the pathology. That's, in my opinion, in my hands at least, the gold standard for L4-5, L5S1, especially at both levels. Going from the belly and from the back gives you better chances of fusion, higher reported patient outcomes. There's great studies by a spine surgeon who actually just moved to Dallas, I found out, who's published on that. So that's why I do enjoy doing consultations at times. But, you know, if it's a consultation for non-surgical options, then I sometimes, you know, there's probably non-surgical specialists that are better than me. What's that called? This is a spine fusion cage. I don't want to say the name. You know, last week, for those that follow me all the time, I wasn't even saying the name. I was showing these cages, and I got blocked for 10 minutes for advertising without permission from a company, which kind of blew my mind. So I wasn't even saying their name. I'm not even going to hint on that this time. But one thing I always talk about also is, you know, why does it matter going through the belly, through the side? One thing I can just point out, first and foremost, people don't want to go through the belly for their spine surgery. Well, look at the difference between these two cages. Do you want this tiny little cube cage in the back and that huge big disc space you have? You want this little thing, or do you want this big fat thing? Do you want this big thing that has more surface area, more height, more curvature, or are you just going to rely on this cute little thing that's the size of a penny, or the big thing? Same thing if you go through the side under the ribs. That's a hard thing. Not a lot of spine surgeons know how to do that. So the reason that's good is look at the size difference in these things. You know, you might be at home being like, oh, I want the smallest thing possible. Well, that's not necessarily the best idea, because the bigger the better sometimes. The bigger the better, because that's more surface area on the bone. So it's less subsidence. It's less ability for this cage to pop through the bone. It also gives you more height, more restoration of your lost disc height, and it gives you more curvature back. So there's just a lot of different advantages there. Again, Some of it's region dependent. Some of it's hospital dependent. Some of the hospitals don't approve that. Some of the hospitals don't have vascular surgeons. So who am I to say, oh, you should go through the belly at 5'1"? Well, your spine surgeon might be in a university hospital. They're vascular surgeons. Don't just do approaches. They do vein grafts. They do a lot of other things. So it's difficult in your university hospital to get an A-lift because that's a lot of work for your spine surgeon. And so they just don't do it. And that's fine. Honestly, that's fine. I'm not ripping university hospitals or, it's a whole different argument. But sometimes different doctors have better access to vascular surgeons because if you put on one of these cages from the belly, you need a vascular surgeon. You don't have to. You need like a general surgeon, vascular surgeon, abdominal surgeon to go through, and they just kind of manage any issues if those pop up. So we're getting a little off topic on that. I see a lot of people saying that's exactly what they had. And then I had someone to say, how do you fix spondylolisthesis? That's kind of what I just hammered. So if you go to my YouTube channel, the video that we're just doing now, go to probably 28 minutes. I just talked about this cage. I won't bore everyone in the crowd. So that being said, I'm going to do some rapid fire questions. I just saw my beautiful wife with our 4-month-old, and it's my turn, which is good, to go hold her. She wants a break, and the baby's not napping. So I'll do some rapid fire questions, and then I do have to go. I do have a life minus doing this, but I like to jump on here. I haven't done this in a couple weeks just because we've been busy with kid stuff. How do I feel about SI joint fusions? I feel good about them. I would say if you're going to have someone do it, fly to Dallas and have Dr. A.J. Rush. He's one of the best in the world. A.J. Rush, have him do it. If you don't want to fly to Dallas, fine, you're lost, but have a spine surgeon do it. How about that? Next thing I say about, next question is, I don't want to fuse my T7 to T11 at 36. I wouldn't either, but if you have a major issue in the thoracic spine, it might need that. If mom was not happy, yeah, that's funny. Do you put in bone graft with a spacer for fusion or the lumbar spine? Yep, I just use the bone from the bone spurs you have there. I also usually use a synthetic bone or a ceramic composite. I don't want to say its name, but ceramic composite. Is there a fail-safe mechanism for laminoplasty? Adam, interesting question. Interesting question. You know what you're talking about. Yes, if the laminoplasty, like if the bones break while you're breaking them apart, you can always do a cervical fusion, and that'd be fine. So I know it's really, everyone at home is like, wait, what are you talking about? But for the guy who just asked that question, yeah, posterior cervical fusion would be the backup plan for sure. Someone told me it was carpal tunnel syndrome. I missed maybe your other part of the question. That's possible. From Pilly, I've seen 2 spine surgeons. You can go through the side. If that's not possible, to go through the back. It's so confusing. Pilly, I completely agree with what that spine surgeon said. I know it's confusing. Yeah, you try to go through the side for most things, but if you can't get it and it's not super duper safe, then the spine surgeon might just do it all from the back. So it sounds like your understanding of it makes sense to me. Again, I don't know anything about your condition, not formal medical advice, but you're saying things that make sense to me, if that gives you any reassurance at home. No more bone dowels. More bone dowels. I don't know what that means. Why is my sciatica back every winter? I'm not sure. Disc replacement, T7, T11. Nope, they're not approved for the thoracic spine. It'd be really, really difficult to get into the thoracic spine also. All right, everyone. Look, it's 42 young to have a fusion. Not necessarily. It depends on what your condition is. You're young, but we're also not going to keep you in pain forever. Look, on that note, I do have to go. I really appreciate it. I'm going to end one stream, and then I'm going to say something more on this other stream. So thanks, everyone. Appreciate any subscriptions. And then with that being said,